Good evening, everybody. Thank you for logging in tonight. We are excited to have you with us. My name is John Beckel, and I'm the Director of Clinic Development with BioT, and I'll be the moderator for tonight's presentation by Dr. Jim Simon. A few housekeeping items before we get started. On the right-hand side of your screen, you should see a box that will allow you to type questions while the presentation is going on tonight. Our goal will be to respond to all of them either in the Q&A section at the end of the presentation or directly through the chat. Please ask as many questions as you would like while the presentation is going on, and we will try to get to all of them. For timing tonight, should take us probably 45 to 50 minutes for the presentation portion of the event. And we'll finish the Q&A and wrap up the call around an hour to an hour 15 from now. As you know, part of our ongoing commitment to you and your ability to help your patients achieve optimal health and outcomes, it's important for BioT to continue to bring a diverse set of backgrounds and experiences to you and your practices. Tonight's featured speaker is no exception. Our speaker tonight is Dr. Jim Simon. He is a clinical professor of OBGYN at the George Washington University in Washington, D.C. He's a board-certified obstetrician and gynecologist, reproductive endocrinologist, and AASECT certified sexuality counselor. As a well-published and deeply established researcher and clinician with over 400 clinical research trials and 800 published articles, his insights and recommendations can provide additional criteria for you to consider as you continuously formulate your own distinct pathways to incorporating testosterone treatment in menopausal women. Dr. Simon brings years of academic and scientific rigor and is the only physician to serve as the president of both the Menopause Society and the International Society for the Study of Women's Sexual Health. I believe every OBGYN on our call tonight is familiar with his work, and to say I'm super excited is probably an understatement to listen to him to speak tonight about testosterone therapy and menopause and the literature surrounding it. Dr. Simon, with that, I will turn it over to you.
Thanks very much, John. I appreciate it. The title of my talk is Testosterone Therapy in Menopause, Finding the Sweet Spot Between Benefits and Risks. So the learning objectives that I put forward for tonight are that upon completion, all of you who are participating should understand that testosterone is a female hormone with a sweet spot between benefits and risks, that testosterone is present in greater quantities than estradiol in adult women of all ages, that testosterone is the principal hormone of sexual desire in women, just like men, and that testosterone has profound effects in women of all ages, extending far beyond sexual function and including bone, body composition, etc. And while I won't be able to cover all of the effects of testosterone in women, I've singled out a few in addition to sexual function for my discussion this evening. Let's start with some basics. First, these are the hormones of the normal menstrual cycle. Very pretty, but highly reproducible. And I want to point out testosterone here in brown, that it basically parallels the production of estradiol here in blue, peaking at mid-cycle and coming back to baseline. And while the testosterone line is very low relative to these other lines, estradiol, the LH surge indicated here, progesterone in the luteal phase, which rises, and along with estradiol rising in the luteal phase, testosterone is nearly always depicted as this very, very low level. And that's one of my major talking points tonight, to dispel this myth and to give you the ammunition to understand just how much testosterone is a female hormone and just how much testosterone normal women make every day of their adult lives. First, a little bit about the sources of androgens, testosterone being our focus tonight. Testosterone in women is made in the ovaries and in the adrenal glands, principally the ovaries during reproductive life, and if they are removed surgically or after menopause, adrenal production becomes much more important. Testosterone is also produced in peripheral tissues, in muscle and in fat. And recognize that testosterone in this biosynthetic pathway can be reduced to dihydrotestosterone, which we will not discuss this evening, but is the principal androgen reacting in skin and sexual hair, and testosterone being metabolized as it is in a normal menstrual cycle to estradiol, the principal estrogen in reproductive aged women. This arrow, while it points almost exclusively from testosterone to estradiol, has a little teeny one not shown where estradiol can be converted to testosterone, albeit not in very large quantities. Well, testosterone goes down, and this is androgens more globally, goes down with age and with oophorectomy. And in each of these three groups of bars, for the four major androgens in women, DHEA sulfate, DHEA, androstenedione, and testosterone, you can see that in young women, these androgens are each much higher than in postmenopausal women. And then after oophorectomy, those androgens made in the ovaries, androstenedione and testosterone, are further reduced compared to just natural postmenopausal women. And it is in those women, oophorectomized women or surgically menopausal women, where the greatest deficiency of testosterone is found. I also want to point out that after natural menopause, testosterone does not fall. So time zero on this graph is the last menstrual period. And while androgens and testosterone are falling from a high level at around age 20 to the level at menopause, testosterone doesn't fall further even within 5 years after the last menstrual period. Well, if any of you have young children, you know how difficult it is to teach them how to tell time. Because to a child, a minute, a second, even an hour, all are the same. They have no sense of time. So they'll say, Mommy, Daddy, just one more minute, but believe me, they mean one more hour. And I want to use that as an example to explain what the problem is with the way we measure testosterone. So testosterone in the US is measured in nanograms per deciliter. Nanograms per deciliter, which are 10-fold greater than the way we measure estradiol, picograms per milliliter. Now remember I showed you that pretty colored graph of the menstrual cycle where testosterone was really a small, low line on the very bottom of that beautiful graph? Well, that's a mistake. It's a mistake that's perpetuated in nearly every depiction of the menstrual cycle. So let's try and put testosterone in the context of estradiol, because most practitioners know that normal estradiol levels are measured in picograms per milliliter. And this slide from my former mentor, John Buster, shows these mean steroid hormone levels all expressed in picograms per milliliter. So we have estradiol in the first row, testosterone in the second row, and the other androgens, androstenedione and DHEA and DHES, as I mentioned, adrenal for these two, ovary for these two, and ovary for estradiol. And you can see that in reproductive aged women in this column, naturally menopausal women in this column, and surgically menopausal women in this column, there's bucket loads, if you will, of picograms of all the androgens, including testosterone, compared to estradiol. So even though we depict estradiol as the most important hormone of reproductive aged women, testosterone is present whether during reproduction, natural menopause, or surgical menopause in 4 to 10-fold greater amounts. So testosterone is a lot of stuff, and estradiol is much less stuff. And so we tend, because of the way we measure testosterone, to minimize its importance, depict it lower on the echelon of important hormones in menopausal or reproductive aged women, and it gets the short shrift. Testosterone circulates in blood, bound largely to sex hormone binding globulin. It is sex hormone binding globulin that responds to birth control pills and oral estrogens that decreases the free testosterone, a fundamental finding that we love in acne-laden, hirsute young women who, when put on birth control pills, get a rise in sex hormone binding globulin and a decrease in free testosterone. And as a result, their skin clears up, their hirsutism goes away, and they feel much better about themselves. Testosterone in women circulates free about 1%, loosely bound to albumin about 19%, and tightly bound to SHBG about 80%. In the brain of both men and women, estradiol and testosterone co-locate in nearly all the places where they function. That is to say that estradiol and testosterone are in the areas of the brain responsible for reproduction, sexual activity, etc., and highly intraconvertible in those locations because of the presence, as I've already mentioned, of aromatase enzyme, which is also present in the brain in large amounts, making estradiol and testosterone intraconvertible in the brain and probably sharing responsibilities for those reproductive functions. This is perhaps my most important slide, and it's one that characterizes the point of view illustrated in the title of this talk, Finding the Sweet Spot. And this applies not only to testosterone, but all hormones. That is to say, there's a normal range where too much gives you side effects and too little gives you lack of effects. This is, in fact, the normal range on what we would assume the sweet spot is. And for all of our hormones, humans have evolved over 100,000 years to have a normal range. So what does all this mean to us clinically? Where are we going with this? Well, let's start out by an example. This slide says changes following oophorectomy in women over 60 versus those of young women going through puberty or adrenarche. And let me just take you through this because it's very illustrative. Young women going through puberty at adrenarche, the point at which androgens begin to emerge as the most important hormones, get an increase in sexual hair, begin to get a libido, desire for sex, have an increase in bone density, a vertical growth spurt, an increase in their muscle mass, and their immune function matures. Prior to that time, they bring home every little sniffle and flu to generously share with the rest of the family. But after menopause, and remember, we're talking about women 60 years of age and older, and this would apply also to women with oophorectomy, they have a decrease in their sexual hair, thinning or absence of pubic hair. They don't need to shave anymore. They lose their libido. They have a fall in bone density, sometimes developing osteoporosis. They get a kyphosis and lose adult stature. They lose lean muscle mass, and their immune function diminishes. It's why older women and older men, by the way, have a resumption in our disorders like herpes, both zoster and simplex, and why we get vaccinated to avoid getting shingles. I'm going to show some examples of the effects of testosterone from studies using methyl testosterone. Now, methyl testosterone is an oral agent. It's been around for a very long time. In fact, it was available and on the market as a treatment for low sexual desire prior to the FDA coming into existence. But it is not testosterone. It's very similar. It just has this one methyl group at the 17th position on the D ring, A, B, C, D ring. And otherwise, it's the exact same thing as testosterone. That methyl group allows for better oral bioavailability and a longer duration of action. So what are we going to talk about tonight? So we're going to talk about testosterone and the influence of testosterone, but we're only going to talk about three things because of time. We're going to talk about bones, the impact of testosterone in the bones and skeleton. We're going to talk about the impact of testosterone on lean muscle and body fat composition, and we're going to talk about sex. All of these other endpoints, eye health, dry eyes, cardiovascular health, cardiac capabilities, response to exercise, cognitive function, mood, and metabolism more generally, they are all impacted by testosterone, but we're not going to have time to discuss them this evening. So androgens in women, we're going to talk specifically about urogenital effects and focused on the vulvar vestibule and sexual desire and libido, as well as bone and body composition. So let's start with the vulva and vestibule. You should know, and if you don't remember, you should know that all humans start out being female in terms of their genitals. So as opposed to what it says in the Bible, where it says that Eve was derived from Adam's rib, I think that's what it says in Genesis. The truth is we're all female, and that the phallus, the male penis, is derived from a very female form at about 8 to 12 weeks, where the male develops and the female remains largely the same. There's a point to this, and I'll get to it in a minute. This is development of the female external genitalia from that indifferent form in utero. And I want to focus on this reddish brown area here. It's not the labia majora, it's not the labia minora, it is the vestibule, the vestibule. This is the normal male, I guess that's another female. Let me get to the next slide. Here's what happens in the male. Starts out looking very female, and that brown area disappears and becomes the penile urethra. The penile urethra, a very sensitive tissue in men, as the vestibule is in many women. So where am I going with this? Well, the barrel of the vagina, or what we call the barrel of the vagina, because our patients oversimplify the whole thing. Everything down there is the vagina. The barrel of the vagina is derived from mesoderm. And mesoderm is the same tissue that ultimately develops in skeletal muscle, bone, cartilage, joints, very tough stuff. And it has an epithelium, not a mucosa, an epithelium with a lot of wrinkles. It's a very tough tissue, the barrel of the vagina. It'll stretch, accommodating a 7, 8, 10-pound baby's head and not tear. The vulva is derived from ectoderm. It's basically normal skin, has hair. Not that we've seen any hair on the vulva in a long time. It's usually taken off or shaved into different shapes, etc. But skin and hair are ectoderm, and they are the vulva, and they are the same tissues that give rise in the fetus to fingernails and tooth enamel. Again, very tough tissues. But the vestibule, as I've shown you, ends up in the male as the penile urethra, and in the female, the vestibule, and it otherwise becomes the insides of the intestines, bladder, stomach, liver, lung, and pancreas, tissues that are never exposed to the outside world. And finally, these tissues of the vestibule are androgen dependent, just like the penile urethra in the male. And so testosterone is likely an important benefit to the penile urethra and also the vestibule. And we showed this in 2 reviews, one on clinical endpoints of androgens in the vestibule, and one on the basic research aspects of these, both published in 2018. Have a look if you're interested. Let's move on to libido. Well, both the male and female libido are controlled by a variety of factors. I'm going to focus on androgens in menopause, but obviously libido has a multitude of inputs because it's affected in premenopausal women who have plenty of testosterone circulating in their blood, as I've already shown you. There are biologic inputs to libido, expectation and past history of disappointing sex, the need for privacy, emotional support, relationships. These are all very important. I'm not discounting them. I'm focusing, however, on androgens and libido in menopausal women or surgically menopausal women. We see this when we look at decreased sexual desire and being distressed about it. And you can see here's desire in the squares from this large study of more than 31,000 American women, showing that there's a problem with desire in women of all ages, but it's pretty low in prevalence, 5 or 7%, up to age 29, rising, and then rising dramatically, peaking at menopause, and then it appears from this data to go down. Well, that doesn't make sense. Dr. Simon, you told us that testosterone is the hormone of desire, and it's going in the opposite direction. Well, this is because this is sexual desire with associated distress. And one of the problems with charts like this is that we don't tease out the distress. So women may have no partner, So they're not as distressed about low desire if they don't have a partner, or maybe they have low desire and that's a beneficial thing because they don't actually like their partner or want to have sex with him or her. So a decrease is seen. But if we tease out distress from this exact same database, here's what you see. Low desire, represented by this line, begins to rise in the mid to late 40s from a baseline in the 20s and 30s, and it continues to rise until the last data point at age 80. There's no data after age 80, and so this is the trajectory of decreased desire following menopause or late in the perimenopause through to menopause. And this is a androgen-dependent testosterone effect, as well as other of those psychosocial aspects I've already mentioned. So reproductive age, normal and ovulating women all have normal testosterone. I'm going to say it again. Reproductive aged, normal ovulating women all have normal testosterone because, as I showed you, they couldn't make estradiol and couldn't ovulate if their testosterones weren't normal. It's only in the late perimenopause, when those menstrual cycles become irregular, and following menopause, both natural and surgical, when testosterone levels are not in the normal range. So here's that same diagram I showed you, a little less colorful. Estradiol peaks, testosterone peaks right around ovulation when Mother Nature wanted females, in this case human females, to procreate, to be receptive to sex or to have sex. And then testosterone falls as estradiol and progesterone falls. And we've already talked about this graph being a lot taller if measured in the same units. Human sexual desire parallels testosterone nearly exactly, peaking just after ovulation when the egg is most ripe and available for fertilization. This is exactly the same phenomenon in rodents and in monkeys. No difference whatsoever. Not that we're animals, but in many ways we are. So let's focus on menopausal women, where women have low testosterone by definition, as I've shown you, compared to younger women, and where we want to find their sweet spot. Well, unfortunately, the biggest amount of data on this subject comes from older studies done on a testosterone patch, which was developed for the US and world market, ultimately approved in the European Union, but then not marketed beyond the first couple of years and never approved for marketing in the US. And you can see on this list a whole bunch of studies, and I'll refer to the data from some of them, from SM, surgically menopausal women, NM, naturally menopausal women, those on oral estrogens, transdermal estrogens, and those not on estrogen at all. This was a transdermal twice-a-week patch releasing, importantly, about 300 micrograms of testosterone daily, which represents the 90th percentile of normal reproductive aged women's testosterone production. So let's look at surgically menopausal women from IntimMedicine. That's a study name, was published in 2005 by me and my colleagues, and it showed this testosterone patch. All subjects got estrogen, or about 500 per group, and testosterone added to estrogen significantly improved arousal, orgasm, pleasure, reduced sexual concerns, and increased sexual responsiveness and sexual self-image, in addition to sexual desire, the primary endpoint of this study. There were some side effects in this development program, not in the 300 microgram group, but in the development program, and they include a very small risk of hair loss, a very small risk, albeit at higher levels, an increased risk of hirsutism, some breast pain, and no significant increase in hot flashes, and some increase in acne and seborrhea. This is a summation of 4 different clinical trials: surgically menopausal women, SM1, SM2, naturally menopausal women, all showing an increase in sexual activity, an increase in sexual desire, and a decrease in personal distress. And all of these, save this last bar here, were statistically significant. Now, what about giving testosterone in women who are not taking estrogen? These are postmenopausal women in the largest single study ever done by Susan Davis and colleagues, published as the so-called Aphrodite study. Aphrodite seen here, okay? And it was published in 2008. And even without estrogen, what you can see is desire, arousal, orgasm, pleasure, sexual concerns decrease, sexual responsiveness, and sexual self-image, all statistically and significantly better on testosterone, the same 300 micrograms per day, and a statistically significant decrease in sexual distress. This study by Noctegal and colleagues, and I was a senior author on this, demonstrated for this patch, giving 300 micrograms per 24 hours over 4 years, the following safety profile. No clinically relevant changes in lipids, liver function tests, hematology, which is a challenge in men who get hypercoagulable and polycythemia. No effects of this dose of testosterone in women on carbohydrate metabolism. A small increase in weight of 1.7 kilograms that was statistically significant over 4 years. Curiously, an informal assessment of that increase in body weight was reported as an increase in weight, but a decrease in dress size, suggesting, although not measured specifically, an increase in lean body mass and less fat mass. There was a small increase in blood pressure over 4 years, less than 2 millimeters of mercury, and there was an increase in the rate of breast cancer, a very big concern to our patients, but that increase was what would have been expected just by 4 years age alone, recognizing that the principal risk for breast cancer, whether on estrogen, testosterone, or not, is age. Let's change to my other endpoint that I promised, bone health. And this study is not exactly what we would like, but it's unique in the scientific literature. It was published a long time ago, 1996, looking at estratest versus Premarin, estrogen alone versus estrogen and methyl testosterone, and showing that there is a decrease in bone resorption that was comparable both in the estratest here labeled as EA group and the estrogen only group, Premarin CEE group, comparable reductions in bone resorption. However, there was a separation in bone formation as measured by osteocalcin, with the decrease in Premarin, decreased formation, comparable and expected with the decrease in decreased resorption, consistent with that, while bone formation in the estrogen-androgen group was maintained. And this was a significant difference that came together when the agents were stopped, suggesting at least that androgen, methyl testosterone in this case, could continue bone formation while bone resorption was reduced. And that's what that says. And in a comparable study looking at esterified estrogens in the same amount as in estratest versus actual estratest, there was a statistically significant increase at both 1 year and 2 years in bone mineral density of the spine, suggesting that that bone formation preservation that I showed you in the previous study could in fact lead to an increase in bone mineral density in similarly treated subjects. Now, one of the things that I hear all the time, nearly every day in my office is, Dr. Simon, are these hormones going to make me fat? It almost always comes out exactly that way. Dr. Simon, are these hormones going to make me fat? And so let's look at the impact of testosterone, specifically on body composition. Weight gain and body mass changes during menopause. We're just talking about the changes that occur during the menopause transition. No hormones involved in this next slide. This is data from a longitudinal, very important study called the SWAN study of women across the nation, federally funded study looking both at ethnic groups as well as women as they transition across menopause. And this is the body weight versus the number of years prior to and after the final menstrual period, here illustrated by 0. And it shows very clearly that body weight begins to go up as early as 8 years before the last menstrual period. It continues to go up until about 4 years following the last menstrual period. And then it continues to go up, but at a lesser trajectory for as long as they've got data in this study, up to 10 years following the last menstrual period. And what I would say to that is, that does not sound too good. And it would be even difficult to say from whatever hormones I'd be giving that patient that it wasn't just her age that was contributing to her increase in body weight. This slide, generously given to me by Dr. Angela Fitch, demonstrates that in the late perimenopause, which would correspond to what I just showed you, that the decrease in estrogen leads to an increase in FSH, an increase in abdominal fat and fat-free mass, okay, a decrease in lean or fat-free mass, and this occurs and has downstream consequences, all of which are bad for health. And these just continue actually after menopause unless hormone therapy is introduced. It's one of the few approaches, save the Wegovy's and Zepbounds of the world, the GLP-1s, that can actually significantly undo and or stabilize these body composition changes. And I'll show you that now. So there are a number of potential causes. I've indicated them to some degree, but according to animal models, estrogen deficiencies associated with reduced energy expenditure, as well as being involved in feeding behaviors and meal size, meaning when estrogen goes down in animals, they eat more, they eat bigger meals, and they tend to choose more fat-dense or calorie-dense foods. Aging and menopause are associated with changes in adipose metabolism, which may contribute to the accumulation of body fat if one has increased calories, and these deleterious changes in inflammatory markers and adipokines correlate strongly with an increase in adiposity at menopause. In other words, inflammation increases fat accumulation in the visceral fat. And then lower SHBG levels increase insulin resistance and type 2 diabetes risks. I hate to beat up on SHBG, but it's also correlated with visceral fat and the adipokine changes in profile I just mentioned in number 3. Other risk factors causing weight gain during midlife are less biologic than psychosocial. For example, environmental and behavioral factors, including low levels of activity, sitting around and eating chips on the sofa, a history of obesity, and marriage at an earlier age, all contribute to increased body fat and weight. And depression, whether it's due to failed marriages, failing to launch your children, other psychosocial issues, challenges of aging parents or grandparents, and or issues with one's spouse, sleep deprivation, etc., can all cause weight gain across these data points. So let's see what can be done about it. This is an old study, again, looking at methyl testosterone, not testosterone, natural testosterone, but I chose it because it's relatively easy to understand and the changes are pretty marked. So these are postmenopausal women receiving both esterified estrogens and methyl testosterone over as short as 4 months of treatment, and they measured their body composition by dual energy X-ray absorptiometry, or DEXA, as we do for bone density. You can also measure body composition. And over 4 months of treatment only, they lost 2 to 4% fat and increased 4 to 6% their lean muscle. And that was compared to estrogen alone, the same estrogen at the same dose, but without the methyl testosterone, where they saw no significant changes. And where did this decrease in fat come in? And where did the increase in lean come in? Well, the answer is, here's the changes in lean in the arms, in the legs, and in the trunk, all better than or increasing lean over the group in yellow, the estrogen-only group. Further, changes in fat, all in the negative direction with androgens, arms, legs to a lesser degree, and trunk being the single most important area. And then finally, percent body fat decreased in the estrogen androgen group at all locations where it was measured. Other studies looking at natural testosterone demonstrate both that lean body mass can be maintained and total fat mass can be maintained, not increased, and in the case of lean, not increased, but stabilized, favoring testosterone as a neutral effect, since lean body mass goes down with age and fat mass goes up with age. Here we see that natural testosterone at physiologic doses could in fact maintain lean and maintain body fat. So what about dosing, prescribing, and monitoring? What's the target blood level? These slides from the International Society for the Study of Women's Sexual Health, or ISWISH. And here are the targets based on age. They're not all that different across the ages. These are total testosterone. The measure that ISWISH decided was the most available and most reproducible. And you'll recognize that these levels are pretty low compared to many you may see in the clinic. If you use international levels, they are listed for you here in SI units, nanomoles per liter. But the answer is they're fairly low. These are what Mother Nature intended. Higher levels would be considered pharmacologic treatment. And Ishwish decided in their key findings that total testosterone was the best and most available assay. Total testosterone and SHBG should be measured before initiating therapy to make sure that individuals you're considering for treatment are in fact in the lower 1/3, and if they're in the upper 1/3 of those ranges, they may not need treatment. One important characteristic is that sex hormone binding globulin above 170, in my personal opinion, based on data from the entire testosterone patch development, those women did not respond to testosterone at physiologic doses in terms of sexual function or dysfunction. So this is a special subgroup of individuals. They are likely to have SHBGs that are very high due to former or current use of birth control pills and oral estrogens. Proper dosing should attain and maintain testosterone in the premenopausal physiologic range. Delivery of testosterone should be about 1/10 a standard male dose. If you're using 1% testosterone, that amounts to about 300 micrograms per day, as was tested in those patches. Ishwish did not recommend compounded testosterone pellets or IM injections, and oral formulations were likewise not recommended because of their impact on liver function tests and HDL cholesterol. So what are the therapeutic choices that Ishwish chose? While men have lots and lots of choices, last I checked, including generics, about 30, women have no FDA-approved testosterone products. Women have no FDA-approved testosterone products. And while I gave you some examples using Estratest or ethinyl estradiol, et cetera, they were never FDA approved. They're still on the market, but they were never FDA approved. So Ishwish published these guidelines, how to do testosterone. We published them in 3 different places, all at the same time, in a woman's journal, in a sexual medicine journal, and a menopause journal, all at the same time. And here's what Ishwish suggested: using 1/10 of a male dose transdermally, and to be worldwide. Remember, Ishwish is the international society. There is a approved product in Australia that is a cream, 1% testosterone cream, specifically approved in Australia for women. Here's the dose. You can get that product over the internet, I believe. And the testosterone product for men that we recommended as being easy to use was Testim, or its generic equivalent, 1% testosterone in a gel, and to use 1/10 of a tube, which is the standard dose in men. And that's the testosterone cream from Australia. Monitoring of appropriate testosterone levels and avoiding excessive treatment would be to check testosterone, total testosterone levels at 6 weeks or after 2 to 3 weeks. If there's a dose adjustment, ask patients for signs and symptoms of excess testosterone, including oily skin, seborrhea, and facial or androgenic hair. If there's no benefit for that patient at 6 months, obviously we felt that treatment should be discontinued, especially when the primary treatment was for low sexual desire or sexual dysfunction. And finally, measurement of SHBG, assessing free testosterone, may contribute to understanding a particular individual's lack of sexual or other response, but those are very unusual cases and that need not be done on a routine basis. And obviously look for androgenic side effects, and those may occur if the concentrations of SHBG are low in places like type 2 diabetes, metabolic syndrome, or obesity. Again, we did not recommend compounded testosterone products. We thought that manufacturing by API and good manufacturing practices, or GMP, was very important. We further noted that systemic DHEA supplementation was not recommended, and in the absence of vulvovaginal atrophy, vaginal DHEA has not been tested and therefore could not be recommended. Although if they had vulvar or vaginal atrophy, there is in the US a vaginal DHEA product FDA approved for that treatment. Laboratory tests and other safety assessments include annual breast and pelvic exams, annual mammography, evaluation of any abnormal uterine bleeding, particularly in individuals who may not be adherent to their progesterone or progestogen therapy, which needs to be in place for women who have a uterus, evaluation of any of those androgenic side effects, some of which may not be reversible, including hirsutism, voice changes, and hair loss. I actually had a patient who was a professional singer who was getting too much testosterone from one of her practitioners, and she actually lost her job. She became a mezzo-soprano or an alto, when in fact she was known as a soprano, and she lost her livelihood. That resulted in a lawsuit. Monitor lipids, liver function tests, etc., annually or more frequently should that be deemed necessary. So there is a potential with transdermal therapy, as the gels I mentioned, for skin-to-skin transfer. It's highly unlikely once the gel is dried, but if a partner, a child, or a small pet is going to eat or lick those wet areas where gel is applied, significant transfer has been documented, although it's rare. So just going back to that 48-month slide I showed you on safety, if your blood levels are normal, in the normal reproductive age range, you should be rewarded with no lipid, liver, hematology, or carbohydrate metabolism changes, little change, if any, in blood pressure or weight, and no change in breast cancer risk. So finding the sweet spot turns out, as I've suggested, to be stay within the normal premenopausal range, even if your patient is outside the premenopausal range. Remember, I've been speaking about naturally and surgically menopausal women, and testosterone deficiency in women, in my opinion, and I've stated this to the FDA as well as broadly around the world multiple times, is a valid clinical entity which merits diagnosis and treatment. And I wanted to show one more thing that should hopefully encourage you to try and keep your testosterone levels in the normal range. This is a publication that we did just a few years ago, 2017, looking at the world literature up to that point. And as opposed to the dose response in men, this is the sexual dose response, where the more testosterone, the better the sexual functioning is. In women, that is true up to that 300 micrograms per day, after which sexual functioning goes down. Not only in this study, but as you can see for multiple endpoints, sexual desire goes down, arousal goes down, orgasm goes up, pleasure goes up, but sexual concerns, which went down in this direction, go up again. Sexual responsiveness is no more improved, and sexual self-image actually goes down with doses of testosterone above the 90th percentile for normal women. And that was also true for a transdermal spray of testosterone available in the UK and in Australia, showing that this dose, approximately the 90th percentile for reproductive age women, had the best benefit, and then sexual benefit went down with excessive dosing. SHBG I've already talked to you about. Just one mention that oral estrogens change SHBG with oral conjugated estrogen to a greater degree than oral estrogen, and to a greater degree than non-oral estrogen like patches, lotions, and gels. I mentioned this 170 number, keep that in mind. And then finally, that SHBG in birth control pill users stays elevated in some women, in a few women, forever. And this is the group of women who discontinued their birth control pills and still maintained an elevated SHBG compared to the average woman at baseline. So with that, I'll call this the end. Thank you for your very kind attention, and hope that there are some questions which I'd be happy to answer. Thank you very much. Have a great night, BioT Nation.
Thank you, Dr. Simon. Wealth of information there. There were quite a few questions that came in tonight. Going to kind of work on them in order they came in, and I'll try to weed out some of the repetitive ones if I'm good at what I'm doing here. But before we get there, I know I'll get a lot of this question. We have a lot of providers on tonight, and some of you are on for the first time tonight. We do keep a recording of all of our past webinars on the provider portal. Give us a little bit of grace. We will all be traveling to our annual Sunsea and BioT event in Cancun tomorrow. So we will hope to have this up on the provider portal for your review, along with the copy of the slides, about 48 hours from now. So on Thursday, we hope to have that up for you. And hopping into the questions, I'm glad you recapped kind of your look back at the testosterone patch data, because it was the first question that came in on the front side of this, related to blood pressure. Was that also age related, like some of the other findings you found on weight?
So I don't know if it were stratified only by age or not. It was a very small increase in blood pressure, less than 2 millimeters of mercury systolic, and over a 4-year period. And that was involving a large number of women. So that's an average number, but I don't know if the older women had a greater increase in blood pressure than the younger ones or not. I just don't recall.
Thank you for that. Next question. Seems like the benefits are retained in testosterone replacement alone. What is the drawback of just using testosterone alone, especially since estrogen use has such a bad reputation with traditional practitioners? Will the patient lose by not using the estrogen with testosterone for postmenopausal HRT?
So I think that it's a very good question, and it really boils down to what are you using the testosterone for? So testosterone, as I showed you, can be aromatized to estradiol and will reduce hot flashes and night sweats in menopausal women, albeit not to the same degree as estrogen, which is very potent in that regard. So if you're using it for low libido, there's no reason, as I showed you in that Aphrodite study, that woman requires estrogen, except possibly local estrogen if she has pain with penetration or vaginal dryness. But if she's having hot flashes as her primary symptom, I think estrogen or an estrogen combined with testosterone is the better way to go for that subgroup of women after menopause.
Question here, how often do you initiate testosterone therapy in hormone-naive patients found to have osteoporosis at age 65 as primary treatment and not using a bisphosphonate?
So that is a terrific question. And here's what I would say. I think that someone 65, having not been on any testosterone or estrogen since menopause, let's say around age 50, needs further evaluation to assess her risks of cardiovascular events, heart attacks and strokes. And then once that's done, a subgroup of women could easily go on what's been suggested here, estrogen and testosterone, or estrogen alone for prevention of further bone loss and prevention of or reduction in fracture risk. But there will be a significant number of those 65-year-olds that will have significant plaque, risk factors for cardiovascular events, where giving her estrogen with or without testosterone is probably not a good, safe plan. And a non-hormone treatment could be a bisphosphonate, as suggested by the questioner, or it could be denosumab or Prolia, or some other treatment, depending upon the circumstance, might be a better choice for that 65-year-old with osteoporosis.
Do you have you spoke to the testosterone patches obviously not being available as a replacement therapy option. Do you know why they weren't approved in the EU and the USA?
Well, so the testosterone patches were approved in the EU and were on the market for about 3 years. They were approved only for surgically menopausal women, and they did not sell well, and the sponsor chose voluntarily to pull them off the market, not because of problems or adverse consequences, but because of business concerns. Those same exact patches were never approved in the US for a couple of reasons. Number one, they came to an advisory panel at FDA exactly following the Women's Health Initiative study, and the sexual medicine experts on that advisory panel got the shivers about the risks of hormones because of what was seen in the Women's Health Initiative. That's number one. And secondarily, the panelist who was the FDA's advisor for cardiovascular risk. Remember that at that time, 2004, the FDA was concerned that the increased risk of cardiovascular disease in men versus the risk in women would be translated to those women by giving them testosterone. And so with the added concerns of the WHI cardiovascular outcomes and the fact that all the data at that time presented to the FDA was on surgically menopausal women, the indication for the patch in 2005, they got cold feet and they said that they weren't going to approve it, and they wanted a 5-year breast and cardiovascular safety study, at which time the sponsor of the patch development withdrew the application. So the patch has never been turned down. The application was withdrawn.
Question here around voice changes. Was there any literature stating what levels of testosterone could cause perceived voice changes?
Yeah, so I didn't go into depth there. It's highly, highly variable. It's variable not only on the testosterone dose, but on the free testosterone, which is affected by SHBG, body mass index, a bunch of other criteria. But trying to keep testosterone levels in the normal reproductive age range, at the most pushing them to 20% above the normal reproductive age range, will typically keep patients out of trouble, both in terms of skin, acne, seborrhea, hair gain like this, and hair loss like this, and voice changes all together. So it's very difficult to pull the wool over Mother Nature's 100,000 years of evolutionary experience. And so I don't have any guidance really about how high you can push testosterone in women without getting into trouble.
How do you approach a PCOS patient in this regard?
Yeah, so PCOS patients who, by virtue of their being premenopausal, have ovulatory dysfunction, androgen excess, increased cardiovascular risk. And the goal there is to increase insulin sensitivity, decrease ovarian production of androgens, decrease any adrenal excess of androgens to kind of normalize that metabolic profile and help her to ovulate if that's part of her goals. If she doesn't want to become pregnant, doesn't want to ovulate, we can use combined hormonal contraceptives to lower her androgenic burden and try to reduce her metabolic abnormality and insulin resistance, pre-diabetes in many of those women. It really depends on what her goals are, but I would work very hard in those young women with PCOS to normalize their metabolic syndrome because it has long-lasting cardiovascular risks associated with it long after her reproductive function is over.
You spoke a few times about elevated SHBG. What are you using to help patients manage higher SHBG levels?
So this is very controversial. I am unaware of any systematic evaluation of any of the treatments that I'm going to measure for that endpoint. So let's imagine that Mrs. Smith or Miss Smith has an elevated SHBG. Let's even give her an elevated SHBG above 170. And let's imagine that she has a decrease in libido and she wants you to help her increase her libido, whether you're going to give her BioT pellets or testosterone or estrogen, whatever you're going to do. And there are, remember, 2 FDA-approved non-hormonal products in the US for increasing sexual desire that are independent of SHBG. But let's imagine we're going to lower her SHBG. One way to do that is to give her a low dose of oral androgen. And what I do in that setting is I either give her a low dose of methyl testosterone. I did a study probably 30 years ago documenting that it lowers SHBG, low dose of methyl testosterone, same dose or a half dose of what's in Estratest. Half dose works also, or to give her a very low dose of danazol. Now, most of you probably never even heard of danazol. Danazol or Danacrin is a very old drug, was used at pretty high doses, 900 milligrams a day for endometriosis-related pain, but as doses as low as 50 milligrams a day will push down that SHBG if that's your goal.
Based on recent findings from the Traverse trial, I understood there were no longer increased cardiovascular risks from testosterone use.
So, a couple things. The Traverse study was a study in men. It's a very important study, but None of the participants were women. That's the first thing. Second thing is you're absolutely correct that there were no significant adverse cardiovascular, prostate, or other consequences in the TRAVERSE trial from testosterone. That should be very reassuring for both men and for women. One small cautionary note, that is the levels of testosterone in the TRAVERSE trial in the men on testosterone replacement were still in the lowest 1/3 on average of the normal male range. So they started out below the normal male range, they were increased into the normal male range, but they were still at the lower end of the normal male range. We don't have data on men in the upper half or the upper quarter or above the normal male range for those same endpoints that I've mentioned for TRAVERSE, nor do we have data for women on those endpoints, say prostate cancer, for the data in TRAVERSE. We need a big study like that, but I would argue, and I would argue vociferously, that if testosterone levels in men that are far in excess of what you see in women do not cause cardiovascular or cerebrovascular events in those men, many of whom were much older, in their 70s and 80s, then it's unlikely that lower doses in the normal female range would have adverse cardiovascular consequences.
Thank you for that. Can a perimenopausal woman benefit from testosterone for the reduction of vasomotor symptoms where the use of estrogen therapy may worsen her bleeding side effect?
So this is a complicated question. So let me tease it apart a little bit, and I'm not trying to avoid the actual question. So if you have bleeding problems in a perimenopausal woman, and they are common, I think you need to address the bleeding problem, not the hot flash issue first. So address her bleeding problems. That can be done with birth control pills. That can be done with birth control patches, vaginal rings, hormone-releasing IUDs, a variety of ways to reduce her bleeding. And if the treatment doesn't address her hot flashes, then adding androgen to the treatment may increase the benefit, albeit not a great enough benefit, if you add in some testosterone. As a subtle secondary measure, there is one study, and one study only in the whole world's literature, that shows that adding testosterone to late perimenopausal women, not with bleeding, just with late perimenopausal bleeding, those women were typically 45 years of age and older, can increase sexual desire. That study's never been repeated. They were getting normal physiologic amounts of testosterone, but they were perimenopausal, average age 45.
Thank you. I'm scrolling through here trying to make sure I've teased out all the questions. I do see a couple more, and I want to be respectful of everyone's time. One that popped up quite frequently on here is, Dr. Simon, have you ever used pellets?
So I did my first study on subcutaneous estradiol and testosterone pellets. It was published in, believe it or not, 1981. The study was done in 1979. So yes, I've used them, I've studied them. I don't use them on a regular basis, but I have patients who have been coming to me for 30, 40 years, and they still want to get their pellets, I would probably be the last one to deny them. I usually offer them alternatives that would save them both money and time, but they are their own bosses and should have autonomy over their own bodies. And if they want pellets, I'll give them pellets, although I don't have a tremendous number of those patients anymore.
Question here on the literature. A lot of the literature, as you spoke about, is kind of dated. Do you know of any actively going on studies looking at testosterone in women?
Yes, there are some studies that are actively being pursued by the company in Australia who makes the 1% testosterone cream that is approved by the regulatory authorities in Australia. But that's about all. I am hopeful that either BioT or other sponsors will pick up the reins and do the kind of studies that the FDA would like to have done so that we can have FDA-approved products for broad swaths of our postmenopausal women, because otherwise we're just limited in who knows what they know, how much do they know, and what's the best way forward. We really need more research in this arena.
Do you have any idea what the primary endpoints are for that study going on in Australia?
I don't. I think, and I could be wrong about this, I think they are largely pharmacokinetic and pharmacodynamic with some clinical endpoints added on, where the goals of those studies are to expand the regulatory approval beyond Australia and to satisfy regulators outside of Australia as to the efficacy and safety of that product.
That makes sense. In your studies, did you happen to look at timing for improvement of your clinical endpoints around desire, self-image?
Yeah, absolutely. So there were multiple endpoints. The earliest we typically see those endpoints is about 6 to 8 weeks. Remember, the primary endpoints of most of those patch studies were the number of sexual events, not desire per se, but the number of satisfying sexual events in addition to desire. And so it takes a while to have enough time for people to do enough counting and having enough sex before you can find a difference between what I would call, and don't kill the messenger, mercy sex and desired sex. And that was typically 6 to 8 weeks. I would focus more on 8 weeks. The primary endpoints of those studies were typically 6 months, but the answer is as early as 6 to 8 weeks. And if it's not working by 6 months, it's unlikely to work. And that's the same kind of endpoints that we saw in the developments of the 2 FDA-approved drugs, non-hormonal drugs for low sexual desire, Addy or flibanserin, and Vyleesi or bremelanotide, both for low desire in women.
And to wrap up here, too, the last 2 questions that came in mostly in the same spectrum here. So what's your preferred go-to method for a testosterone treatment for a female patient? The cream, stroke, gels?
Yeah, so usually it's highly individual, taking into account what the patient wants, what her risks are, what her family history may be, and what symptom I'm trying to treat. If it's low sexual desire, it might be one approach. If it's arousal disorder or orgasmic dysfunction, maybe a different approach. If it's lean body mass, it may be yet a different approach. But depending upon that approach, my typical go-to for testosterone would be transdermal testosterone gel, as I've already mentioned, and consistent with the ISHWISH consensus document. And then lastly, I do have a number of patients that I manage virtually from around the world, and many of them get testosterone cream from Australia, which is very standardized and easy to use for patients, and has a cold cream or moisturizing cream feel to it, kind of like Olay, for example, and they like it because of both its efficacy and its pleasant application characteristics.
Excellent. I think we knocked them all out. We went a touch longer than I had hoped for, but it was some great questions along with great answers. I do want to thank everybody for taking time out of your schedule during the week. It's late on the East Coast. Dr. Simon, thank you for taking your time as well. We apologize for a couple of weeks ago when there was the national outage on the GoToMeeting platform, and had a great turnout tonight. Look for the recording on Thursday on the provider portal. With that, we will say good night and hope to see a lot of you this weekend in Mexico for our Sunsea event. Thank you again.
Thank you all.